Okay, so I'm doing this pretty late at night, and I just felt like doing one more before going to bed. So I'm going to be talking about Chapter 21 right now, and this recording will include some therapies, some oxygen therapies. I didn't include all of them, I didn't really go into depth with chest physiotherapy, and I did not go into depth, or I didn't talk about nebulizers or anything. So, here we go. Methods of oxygen therapy. So basically we have two types. We have low flow and we have high flow. So low flow contributes partially to the inspired gas. Okay, so what does that mean? That means, let's just say that the air that the person is receiving from the machine, half is taken from the machine and half is taken from the environment. So the person is breathing air, like room air, and he is breathing air or gases, or like a gas, or just air from the machine. Okay? Just simply put, it's half and half. An example is a nasal cannula, partial rebreathing mask, and a non-rebreathing mask. I have no idea what those are, except for the cannula. One thing about the low flow is that this air cannot be specific. They can't turn a dial and give this person that specific kind of a specific amount of oxygen. High flow. So this provides the total inspired air. So this person is not getting any air from the environment. He's only getting air from the machine. And with this type of machine, there's a specific percentage of oxygen that is being delivered. Okay? And it's independent of the patient's breathing. So what does that mean when it's independent of the patient's breathing? It means that it doesn't matter how much the person is breathing. This machine is going to be probably administering a set amount. It is not adjusting based on how well the person is breathing or how bad the person's breathing. It's just giving a set amount. That's my interpretation of that. I would say if there's one thing you want to remember from the slide, it is the Venturi mask. The Venturi mask is the most reliable and accurate method for delivering precise concentrations of oxygen through non-invasive means. Okay, so this is a high flow mask, and it's the most accurate way to deliver oxygen. Remember, Venturi mask. Next slide. Endotracheal intubation. So, the next slide goes into a tracheostomy, which is, well, forget about this. Okay, so forget about that right now. So endotracheal intubation. This is basically where a tube is inserted through the mouth or the nose, and this tube will basically kind of supply this individual with oxygen if necessary. And these are usually given to people that cannot breathe on their own, or have severe obstruction to the respiratory tract. So these are I would say mainly done for people that are in coma state, like in an unconscious state. Really people that can't breathe on their own. This is like an emergency situation. So once this tube is inserted, a cuff is inflated to prevent air from leaking around the outer part of the tube in order to minimize the possibility of aspiration and secure the tube. So what happens is they insert the tube, and there's a cuff around by the bottom of this tube. When they inflate the cuff, it blocks all passages, all possibilities of air leaking through. If air leaks through, this individual could aspirate or begin to aspirate, and choking could occur. So that's why that cuff is inflated at the end of this tube, is so that it can block out the air. That way, air is only going through the tube, in and out through the tube. This tube only is, the endotracheal intubation only is for 14 to 21 days. After that period of time, the person might not need it anymore, or hopefully they won't need it anymore, or they would upgrade to the tracheostomy tube, which is what we'll be talking about next slide. The pressure of the cuff is checked every 8 hours. That is also, I think, important to remember. The pressure of the cuff is checked every 8 hours to make sure that it hasn't deflated, and to make sure that it's not overinflated. So it should be less than 25 millimeters of mercury. And why is that? It's so it doesn't cause trauma to the tracheal walls or to the trachea. And we make sure that it's over 15 millimeters of mercury. And this is to prevent aspiration, because if it's too deflated, then air could be leak or passing by, and we really don't want that. So measures must be taken to prevent premature or inadvertent removal. So if somebody's pulling at their tube, they could actually die if they try to remove it too early. Because I'm not really sure why, but I'm sure it has to do with something about not removing it the proper way, and something really bad could just happen. So you have to prevent this person from taking it out, even if that means restraining them. So next slide. Tracheostomy. This is a surgical opening into the trachea. So you can see this picture right here where a tube is inserted into an opening made in the trachea, and it's inserted, in the trachea. So what does this do? It removes secretions. It can be used to remove secretions, prevent aspiration, and replace an endotracheal tube like we just talked about. This can be temporary or permanent. Suctioning is used for this. We want to do not too much and not too little. So suctioning is usually done when you can hear somebody's breath sounds, like when they're abnormal breath sounds. So adventitious breath sounds. And you don't want to do suctioning too much because it could cause trauma to the tracheal mucosa. So again, be careful with the suctioning. Do not do it if it's not needed. Pressure of cuff. Again, this is exactly the same information as the last slide. Check every 8 hours, and less than 25 over 15. Final slide. Care of patient with being mechanically ventilated. So I just took out a couple things from what I read. I'm not sure if this is everything that we need to know, but I would just recommend you go back yourself and just look over it. So 2 important interventions in care of patient mechanically ventilated. So one is pulmonary auscultation. You want to listen to their lung sounds to make sure that fluid is not accumulating in their lungs, or like secretions are not accumulating. And you also want to interpret arterial blood gas measurements. So you want to, measure their blood gases. So check their CO2 levels or their bicarbonate levels or something. The nurse assesses for the presence of secretions by lung auscultation at least every 2 to 4 hours. Frequency of suctioning determined by patient assessment. So what does that mean? That means that if somebody is constantly coughing up secretions or something, or there's lots of secretions by this individual, you want to suction based on how much they are secreting. Okay, and it's not normal for somebody to be secreting or have lots of secretions every 1 to 2 hours. That is not normal. So you wouldn't be suctioning somebody every 1 to 2 hours typically, but in some cases you would, based on their illness. Measures to clear the airway of secretions include suctioning, chest physiotherapy. So chest physiotherapy, some examples would be, cupping using vibrations, oscillation, which is that kind of band that you put around somebody's chest, and it causes, I think, vibrations, and that stimulates or causes or mobilizes secretions. All of chest physiotherapies mobilize. The goal is to mobilize secretions. So tapping on somebody, positioning somebody a certain way to move the secretions, having them move around. These are all goals these all encourage mobilization of secretions. So frequent position changes. So hopefully this helps you, and take care.